Doesn't sound pleasant to me.
In the beginning of the pandemic, I would try to run with my mask on outside in New York City, and I'm like, this is just going to kill me.
Probably build your capacity. You saw the sprinter in the Olympics that had asthma, right? I think he built his capacity in some fashion.
Oh gosh, I didn't feel like I was building my capacity.
All right, should we get started? I think it's just 1 past noon. Welcome everyone to our monthly CMDA meeting. We're excited to have you. Thanks for taking time out of your day. I think that we will start with our pearls from our partners, and I'm looking to see if Chad Fear with CDPHE is on, and I don't. Chad, are you hiding somewhere?
I haven't seen him log on yet.
Yeah, if not, we'll kind of go down the list if Jenny
Yep, Jenny's here.
Albertson, would you like to present your update for us?
Sure, absolutely. I will share my screen if that's all right with you.
Perfect, thank you.
Okay. Here it is. I have the wrong tab up. It's coming. Okay. All right, you can see it?
Yes, thank you.
Okay, I'll be relatively quick here, but there is a lot to share, so bear with me. Okay, first off, we have a new final rule from CMS for the prospective payment system for the year, and I know that this is perhaps not terribly interesting to all of you, but I want you to be aware of a couple of things that will impact your providers that you work with that may potentially have some impact down the line for you all as well. So our Medicare rates are increasing a little over 4%. So 3% is built in for inflation, but they added a 1.2%. Don't get too excited. They carve out 2% of that as a withholding that then is attached to value-based purchasing. So you may have heard about, of course, pay for performance as a state level. There's also a federal level of value-based purchasing for our Medicare reimbursement. So even though we're expecting an inflationary increase, some of these reimbursement increases will be tied to our performance measures. So be prepared for kind of a level set. It doesn't look like it's going to be anything magnificent. The biggest whammy in this final rule is that they have enhanced the enforcement provisions for the state and the feds to assess civil money penalties. The reason why this matters to all of us is that they've changed the way that they can assess a penalty for a deficiency that's cited at a survey to not only per instance, like this happened one time, so you get a several $1,000 penalty for this particular patient having this particular medication error or whatever they're citing, but they can also assess it going back, and they can simultaneously assess it for per day penalty. It used to be that you could do one or the other, and now they've expanded their ability so they can cite multiple deficiencies simultaneously with penalties assigned to each one per day as well as per instance, which could drastically compound the amount of money we pay out in a set of survey deficiencies. So this is kind of aimed at penalizing what the government sees as people who profiteer on the Medicare and Medicaid system with poor quality of care outcomes. That's what the aim is to penalize those individuals. Unfortunately, what they don't understand is there's really a bifurcated system in skilled nursing. And I think I've touched on this with you all before. There are the ensigns and the life cares that own their properties and don't have to pay real estate investment. And so they get to keep their profits and reinvest them in the care that they provide. And you actually see kind of an improvement in quality of care in those environments based on spending. And it correlates negatively for those that have to actually pay landholders. And they are operating and provide the operating system, but they pay a debt load out of their profits. So unfortunately, CMS does not see the two as separate. They see us all as the same. And so we're going to see some providers suffer disproportionately with penalties because they just frankly can't afford them like those that make profits can. And then there were a couple of quality measures that rolled out. This is separate from the announcement that CMS just made. There's new quality measures that are being rolled out for the new fiscal year as well. This is connected to our MDS reporting, and I want you to be aware because you directly impact these quality measures. This first one is a discharge score. So they've taken away another metric around discharge and changed the way we ask questions around that, and they're focusing just on residents who have improved their ability to discharge and return to the community for a short stay. If a resident's had an incomplete stay, as in they go back to the hospital, they're carved out. They're not included in this number. This is just those who've been able to fulfill their actual post-acute stay under Medicare Part A. And they've carved out, of course, people that have lack of ability to improve, like a vegetative state, locked-in syndrome, brain damage, and then they've also carved out hospice. So they've looked at it correctly as far as I'm concerned. I'm really going to be very curious about how this impacts our overall quality measures, because this is something we're invested in, right? We give therapy. We hope that the person is prepared for discharge. This is what our whole post-acute care plan is aimed toward, and we're going to now be able to track that in our quality measures. So that's kind of exciting. And then COVID vaccination rate, they've added it to the quality measures. They just can't get enough of tackling COVID vaccination from every direction. So now it's part of the MDS, and basically if someone does not comply with being up to date according to the CDC definition, they count as not vaccinated. So it's very plain and simple. Simple numerator denominator, and essentially our quality measures are going to be directly impacted by vaccination rates, not just for flu and pneumonia as they always have on the quality measures. This was a news set of articles that came out in the Times, in Stat News, and I believe also on McKnight's, a big hullabaloo coming out about how we are going to be short geriatricians. We are already short geriatricians. We talked about this at your conference. But I thought I'd highlight some of the current articles here for you all to dig into if you choose to. All the links are live. Basically, we're going to see this continue because we don't, of course, have rotations in our medical schools for geriatrics. I love this quote at the bottom. All medical students are required to have clinical experiences in pediatrics and obstetrics, even though after they graduate, most will never treat or deliver a baby. Yet with the changing demographic landscape, older adults will account for an increasing proportion, and healthcare providers get no exposure to that. So yeah, I'm preaching to the choir here, but I thought you might appreciate the references. One more update here before I give you just a couple of calendar updates. CDPHE is changing their COVID policies. This is not a major impact to you all, but I want you to be aware. They've made our reporting process during outbreaks a lot simpler. It's now via email. We don't have to do weekly line lists anymore. It's a closure line list at the end of an outbreak. They're not treating it nearly as urgently as they did before, in other words, which is great. We've been waiting for this ramp back. That's, of course, simultaneous with an increase in COVID rates, almost equivalent to winter right now nationwide, and particularly in the West. But I'm going to take it. And then they're also reverting to local public health. You'll remember at the beginning of the COVID wonderfulness of the pandemic, we had the local public health agencies trying to carry the ball before CDPHE had any funding to run their COVID response unit. And that's what we're going back to now. They are downsizing and closing their COVID response department at CDPHE. They've lost their funding at this point, or exhausted it, timed out. And so it's diverting all the outbreak management to local public health agencies again. And then our upcoming education is extremely thin, and you know why? It's because our fall convention is coming up in Loveland on September 10th to 12th. I really hope to see you all there. And of course, today I'm running my Pay for Performance webinar series, and I'll continue to do that through the end of the year. But that's it for education between now and the end of September. So thank you for having me today. It's good to see you all.
Thank you so much, Jenny. It's always helpful. Great information. I think, Chad, are you available to give updates for CDPHE? I think you're muted.
Oh boy. Can you hear me now?
Yeah.
Oh, the challenges. Yeah, great information, Jenny. Jenny told you where we're going. So I guess I'll tell you where we've been. And as far as CDPHE goes and the nursing facility section, good news, we resolved our backlog, our recertification surveys. Some of those facilities were 40, 45, 48 months since the previous recertification. So we're glad to have resolved that. Some not so good news in our efforts to resolve that backlog. We have a list, a short list, but somewhat growing list of facilities that are now overdue. And overdue for us is 15.9 months since the previous survey. We are finalizing contracts and wrapping things up so that we are going to be able to use two different contract survey agencies to help us regain that ground and make sure that all facilities are not overdue. We anticipate being able to accomplish that by the end of September. And then going into October, we're going to see us get much closer to our other metric, and that is having a 12.9-month average. So we have a little bit of concern because we are creeping past that deadline for some facilities, but there is hope and there is a plan that we will be putting in place to be able to catch back up. Again, with some of where we've been, I wanted to let you know that the average number of deficiencies for recertifications, we're at 7.43 citations per survey. Colorado's at 8.21. I don't know that that's statistically significant. Complaints nationally were 0.91, and in Colorado, it was an even 1.00 for citations on average for complaint surveys. I mix this up a little bit. Often we'll share the most frequently cited regulations in rank order for deficiencies. And this time I've broken it down into the number of times a tag was cited since October 1st. Of course, NHSN reporting has been far and away the number one tag for Colorado and across the United States. That is, of course, if the reporting isn't completed on time, and it is a citation that is given directly from CMS. So we really don't touch that particular issue. Infection prevention and control, and might I say, the NHSN reporting, there were 224 citations. For infection prevention and control, the second in the list, and number one citation being cited by Colorado surveyors, we had 85 surveys where that was cited. Accident hazards, there were 62 citations. Medication storage, 54. Sanitary food service, 52. Abuse, 49. ADL care for dependent residents, 35. Quality of care, 28. Respiratory care, 27. Since October, we have cited pressure ulcers 25 times. Significant medication errors, 24 times. Environment, 23 times, and professional standards, 23 times. I think, you can look at the list of things that have been cited and probably recognize that there's a lot of ways that there's a lot of things that facilities need to do to be compliant with those regulations, because it covers so much, particularly infection control, accident hazards, and sanitary food service. In terms of the PBJ reporting, which is another requirement, there were 2 facilities with no reporting for NHSN. 8 facilities were flagged for not having an RN 8 consecutive hours, 7 days a week. 6 facilities flagged for having a 1-star staffing rating, and 5 facilities were flagged for having low weekend staffing. I just wanted to update you as well. so that maybe going back to your buildings and having these conversations, in your quality assurance meetings, QAPI, but the immediate jeopardy situations that have been cited for this current fiscal year have included abuse 3 times. We found IJ, one was a staff to resident, the other 2 were resident to resident situations. Quality of life. There were 2 citations for non-pressure related skin conditions. 3 IJs were cited for accidents, and there's a variety of things there. We had concerns with WonderGuard systems not working, unsafe smoking, and then there was another one for egress and evacuation practices. An immediate jeopardy was cited for respiratory care, another one for behavior services. There was an IJ cited when the system failed to report and provide follow-up with pharmacy recommendations for significant medications. And we also had an immediate jeopardy for significant medication errors. Some that we don't typically see, but there was an IJ cited for food textures, which were dangerous to the person based upon an assessment of their needs. Sanitary food service, and here it was sanitizing your cookware and dinnerware. And then there was a life safety immediate jeopardy cited related to the fire suppression system. So again, that's kind of where we've been, and that's my update for you for today.
Perfect. Thanks, Chad. I think since we have a packed schedule, I'm going to go on with the next couple of speakers. If you guys have questions, if you want to write them down, then we'll do a quick question section. But we're going to move along, and we're excited to have Telligen, and Mariah Payne is going to give us an update. And Mariah, you are welcome to share your screen, and if you're able to do that. If not, I can pull up your slides for you.
Awesome. Thank you. I'll go ahead and I'll share my screen. All right. Are you able to see the screen okay?
Yes, we are.
Yes.
Thank you.
Great. So just really a quick update as to what Telligen has been up to recently. One of our biggest projects has been assisting with on-site immunization clinics. So we have been providing outreach to support nursing homes that have been identified with low COVID-19 immunization rates. And when we first started this outreach, we learned about a couple of the barriers that they were experiencing that was contributing to that low uptake. Some of those barriers being vaccine hesitancy, billing, the staff burden for coordination of the clinics on site and documentation of the immunizations. And then lastly, the access. We learned that facilities were not meeting the minimum number of residents at one time for the pharmacy to send an immunization. And when facilities tried to schedule maybe an on-site clinic with their pharmacy, that they were winding up having to schedule multiple times to try to get the pharmacy in-house. But due to the pharmacy experiencing staffing shortages, they were unable to come on site and provide a clinic. So as a result, Telligen partnered with Community Pharmacy Enhanced Services, CPESN, to bring the immunizations and clinics on site to the nursing homes. The new program was launched in February of this year, and we sent outreach to notify the nursing homes of our new program. And our first clinic occurred in March. This program is concluding at the end of this month. The last day for signups was in July, so we do still have quite a few of the nursing homes that have clinics pending for both residents and staff. To date, 54 nursing homes in Colorado have requested an immunization clinic, and 23 of those nursing homes have successfully completed the on-site clinic. This is just some of the data from our clinics from March to June. And so there was a total of 629 residents COVID-19 vaccines administered, 4 influenza vaccines, 146 pneumococcal, and 164 RSV vaccines. administered for residents. The number of influenza immunizations were low, just due to when we were offering this program, that they had already been administered, and it was towards the end of flu season. And one of the things that we also noticed that was across the board was just a decreased staff COVID-19 immunization uptake. One thing that we found really interesting here specifically in Colorado were that 33 of the 38 for March to June, nursing homes that had requested a clinic were in urban areas, whereas in our other states, it was in rural areas. And then here is just some of the impact from these clinics. Based on this graph, you'll see in the orange, it's showing 48%. And this is about 2 weeks after these clinics had occurred. And this is just due to the delay in the NHSN reporting. And so increasing the COVID-19 immunization rates for residents from 33% to 48%. And then you'll see right over here on the right with the yellow bar, it goes to 47%, which could be related to resident discharges and admissions. So even though the program is ending, we have had a lot of nursing homes just reach out and talk about the connections that they've built with their local pharmacies, and so that in the future they could potentially coordinate those clinics in the future. We really try to be solution oriented and not just share resources. And so this project was really initiated because we heard that feedback from nursing homes when we provided this outreach. And this was to put together a plan for mitigation and action. But with that, that's all I have for an update for Telligen. I'll hand it back over to you.
Thank you so much, Mariah. That was really great. We do have one quick question in the chat from Dr. Eber. Will you have any clinic assistants for the fall? And it sounds like this program is closed, or?
As of right now, the program will be ending at the end of August.
Okay.
And Chris, if this is Christine Lorek, Mariah, great job. If you're having trouble with, I heard trouble with NHSN reporting for some of the homes from Chad's presentation, please reach out to Telligen. Reach out to us really for anything. If we don't know the answer, we probably know who does. And really appreciate everybody on the call.
Thank you.
Yeah, our new contract just hit the streets. So we're in neck deep in responding to that proposal. And so more to come about what happens in the fall with continued vaccination assistance. Perfect.
Thank you, Dr. LaRocca. Well, that was a great segue into our next presenter, our very own vaccine expert, Dr. Greg Gahm, is going to tell us all the many reasons to get jabbed in the arm this fall.
Yeah. Hey, Mariah, that really was perfect timing. Let's see, Chris, do you have slides, or do you want me to try to bring them?
I have them, and yeah, I have them. Let me pull them.
So while you're pulling them up, I'm going to just talk to Christine. Christine, does that mean you guys, I haven't heard, you guys got the contract that we were?
I wish that were the case, Greg. We saw the draft the first week of October, and then just on June 25th, the real thing proposal hit, and we respond to it. It's due September 10th and should be awarded roughly the first week of November, if all goes well.
What a long process. Sounds like the government.
I'm getting my gray colored a lot more often now. Yeah. Mm-hmm.
Yeah.
All right.
Oh, there we go. All right, Chris, are you gonna?
Can we still see him?
Yeah.
Okay. We're just looking at the notes screen.
Oh, I don't know how, I did not pull that up, but I said slideshow. There we go.
Okay, great. This won't take long. We're just going to go through the basics. We got more and more vaccines, it seems like, every year. So flu, it's interesting. It's been almost 2 years now since the WHO or CDC have found B. Yamagata. So they're no longer putting that in the vaccine. So we go back to 3 antigens, trivalent vaccine instead of quadrivalent. And so it'll be what we're used to. All right. Next, Chris. Okay. I have no clue this year. With COVID overlying flu, it comes early, it stays late. It just is too hard to predict what's going to happen. One of the strains is brand new, but I don't know if that's going to matter or not. So we'll just have to wait and see. Just a couple clues. Remember to get yourselves vaccinated. It really does make a difference. And you have to report that. Remember also, when you get vaccinated, let your nursing homes know, because they have to report that data of everybody that was vaccinated in their facility, including you, and they have to have it done by December 31st. For anybody, this never changes. If you're over 65, give high dose or adjuvant vaccine, and they're roughly equivalent, so you can just go by whatever is being supplied. Couple quick notes, because flu is making the headlines in a lot of ways. Just a brief background. There are 18 different hemagglutinins, but only 3 of them, 1, 2, and 3, normally infect people and are transmissible person to person. There are 11, there's a typo. There are 11 different neuraminases, but only 2 of them, N1 and N2, normally infect humans. So that's where we get those combinations. The others in different combinations are found in all kinds of animals, birds and tigers and whales. And I often, every time I look at this list, I wonder how somebody found this in whales and who's going to go do their swabs. But at any rate, that takes us to avian influenza. There are lots of different combinations in birds. The one that is hitting right now is H5N1. It's hit across the US, it keeps growing, but anywhere from 150 to 200 herds of cattle. There have been anywhere from 10 to 30 known human cases in almost 24 states. And it's usually a mild respiratory disease, lasts days to weeks. But there was just, there have been a couple reports just in the last couple of weeks of people now doing what we did early in the COVID outbreak, going to look at asymptomatic people and finding that about 15% of asymptomatic farm workers that work on the dairy farms where there were known positives are also positive, have antibodies. So there is asymptomatic spread as well. It's not yet transmissible from person to person, but if you look at the genetics of it, there's only 1 or 2 more random mutations that need to happen for this to be able to go from person to person. So right now, people really have to get it from direct contact with animals. And the animals most likely to get it from are pigs, cattle, and birds. The virus is spreading between cows, probably from contaminated milking equipment rather than airborne particles, which would be something completely different for influenza. But once airborne transmission is possible, we really could be looking at the next pandemic, especially since we're only a couple mutations away from being able to make it person to person. Wealthier countries are purchasing vaccine against H5N1 and boosting surveillance. And then I just wanted to comment back when, well, yeah. You can go back if you want to. One thing worth noting is even though it's N1, there are, who knows, hundreds of thousands of different individual variants of N1, but they always have a lot in common. One of the things you can do to help you on coming avian flu vaccine pandemics, The more years that you've gotten vaccinated for flu, there's always an H1N1 component. So you're seeing a lot every year. You stack up one new version of N1 that you've seen. So down the road, a year, 2 years, 5 years from now, if there's an H5N1 or an H7, 9, and 12, or the other 3 real common avian flus, with an N1, you may be somewhat protected just because you got all those N1s and immunity built up to them. And I also use that with patients that are hesitant to say, well, because if you get other variants of bird flu in the past have been almost 50% mortality rates. This one, the H5N1, not as bad, but hard to say. Okay, now you can go, Chris. That's it. RSV recently changed from the shared decision-making model. That was sort of a politically correct thing to do that just didn't work. So they abandoned that, came up with real specific criteria. Anybody over 75 should get it. If you're 60 to 74, increased risk for RSV. These are the 6 most common conditions that would put you at risk. You should get it. If they get it, they're typical cold-like symptoms again. And they're about, in the US right now, about 6,500 adult deaths per year. Influenza, for comparison, 25 to 50,000. So not up to influenza numbers yet, but certainly not zero. The vaccine itself is really good. Efficacy, 85, 95%. There are now 3 different vaccines. Initially, there were just 2. There's now a new mRNA RSV vaccine also available. Okay. I just threw this in because FDA recently, a couple months ago, approved a 21-valent conjugate vaccine called Capvaxive because it covers more than 80% of the pneumococcal strains that are seen in people, and Prevnar 20, which is really good, but it only covers 52% of the serotypes seen in people. My guess is that there'll be a time when this is available that CMS will say, we want everybody to have it. So, I mean, not right away, because it should be available later this fall. But when it is available, it's worth getting. Okay. Oh, was there a question?
Yeah. Okay.
Your age group, I'd need it over 75.
Okay. COVID, who can tell? There'll be a new COVID vaccine approved either this month or next month. I know that Jenny shared, about being up to date. I don't know if that means we're going to need to be up to date by the end of the year with this one, if that's going to be up to date, or if it's just having gotten the last one with a booster. I don't know what up to date will be, but there will be a new vaccine. My guess is by this time next year, what we'll probably have is a combined influenza COVID vaccine every year, and probably a COVID booster in the middle until things settle out. There we go. So you can read the rest of that. There are still a lot of people dying from COVID, 2,600 people a week this year in January, whereas 3 years earlier, it was 26,000 a week. So we've gotten much better, but it's still, again, not zero. Okay. Shingrix, I just threw that in there. It's easy to forget about it. Not as deadly, but boy, it's nasty if you have older folks that get zoster, and it's got long-lasting immunity. So it certainly is a good vaccine. Anybody immunocompetent over age 50, 2 doses, 2 to 6 months apart. And I think that's it. Questions, and if you need any specific references, let me know.
Thank you, Greg. Thanks so much. Again, I appreciate everyone's patience. If you can write down your questions and hold off, we've got one more excellent presenter, and Dr. Leslie Eber is going to introduce him.
Yeah, I'm so excited to introduce Alex Bardakh. He's the Director of Public Policy and Advocacy for AMDA. He's on the board of the American Association of Medical Director Society Executives and chaired their annual conference this year. And he has been instrumental in getting a medical director registry, promoting issues involving reimbursement for post-acute long-term care. He's been just phenomenal, and we're so happy to have him here today to give us an update. Thanks, Alex.
Oh, Leslie, that was a very late-breaking introduction. Thank you. That's awesome. Appreciate that. You've been following, I guess you've been following me. I don't know if I should be scared or thankful. Maybe both. But thanks. So you've already had the excellent presentation on the summary of the SNF rule that came out. So that was great. So I'll cover it. So this, I just did this at the Georgia meeting in Savannah. So this was an hour-long presentation, the slides. So to make it easy, I just use the same slides. So you'll have them, but obviously I don't have an hour, so I won't do that. So I'll just highlight a few things. So that the legislative outlook right now, you're talking about Congress. They're not in session in August. Hopefully you know that. And so the big thing right now is election. That's going to take up pretty much all the air out of anything that happens in Congress. Everybody's back in their districts and campaigning for their own elections, for any contested Senate seats. So there's a lot going on. The vice presidential nominee on the Democratic side was just named, the governor of Minnesota. So there's a lot of that going on. As far as bills, still 4 and 8 is sort of a big topic that's going on. So obviously that's a big issue, and must pass bills. What that means is the omnibus bills. So there's going to be very few standalone pieces of legislation. As I mentioned, first of all, they don't have that many quote unquote working days left. Second of all, it's not likely that small bills pass at all. And I'll talk about the impact of that as we get into very specific issues. So what you'll see is one big legislative package toward the end of the year. And that's where everybody will try to shove everything they possibly could. Just to reiterate, there's an election. You've probably seen this if you've heard me present at either the national conference or anywhere. You've seen this already. The point that's highlighted is the staffing requirement. I'll go into where we are with it. But there's, a number of other things that this administration is still trying to accomplish. The SNF rule continues to do some of this stuff. The value-based purchasing program you've already heard about, additional measures on the COVID vaccine and others. So they are well on their way trying to implement as much as they could in terms of this came out 2 years ago now. So as you can tell, they're moving along, and they're going to try to do as much as they can. Or they're trying to do as much as they can, given the potential for an administration change. We do know that there's going to be an administration change. The question is, of course, does the political party change? But we know that an administrative change could change the priorities. Vice President Harris, if she becomes president, may have very different priorities than President Biden and others. So we'll see where this particular thing goes. You should already know about this, about the whole medical director registry, as Leslie, thank you for already mentioning that. CMS is well on their way to implementing this. They are collecting this data right now. They're going to be publishing on Care Compare. We have gotten concerns from other chapters and individuals that are basically getting emails saying, hey, give us your social security number. I don't know why people are hesitant these days to give that out, considering it seems like with every cyber attack, it's already well known. But it seems like people still don't want to just email it to anybody, which I still would support. But in all seriousness, you should be talking to your facilities about this because they need to have a plan as to how they're collecting this information. They're just trying to fill out a very standard CMS, what's known as 855I form. If you're a physician that it's in Medicare, you filled out something known as an 855A form, which is a very similar form, and they already have most of the information that you're being asked about in your role as the medical director. So there's not a whole lot of new information here that they're trying to collect, but it's based on this CMS form. So just to be very clear about that, if you have any questions, please, if we don't have time today, just reach out and let us know. So talk about staffing really quickly. This is, by the way, it's not random children. That is my daughter, who's been swimming this summer and played softball last year. So, got to put her in there. So they hit it out of the park with the staffing rule. So the final rule is already out. Hopefully you know that. It changed a few things. They did put in LPNs. They established a minimum staffing ratio of 3.48. And so, you know, depends on who you ask. If you ask the industry organizations, if you will, leading agent ACA, they will tell you it's complete doomsday. Nursing facilities will close. This is a fairy tale, etc. That's what was put out there on social media and continues to be the battle. If you ask the consumer-based groups like Center for Medicare Advocacy, which does a lot of litigation on behalf of consumers, and Consumer Voice, they will tell you that this is needed yesterday and we need to do more, and you know, how dare they not already be implementing this. So depends which side of the aisle you're coming from. So what were the details? As I mentioned, 3.48. 0.55 of those must be by an RN, which could also include your director of nursing. But there's also this requirement that there be a 24/7 RN on site. So, you know, we'll see how that all works out. You should be already in the throes of getting the facility assessment. The facility assessment guidance came out in June of 2024, so a couple months ago. And they're actually happening, I think, in a couple of days. They're supposed to be done. To help with the workforce development, because they've heard the outcries of not enough staff, they're giving a whopping $75 million. And if you translate it into congressional dollars, that's probably about 7.5 cents. And if you translate that into what's needed and the estimates that have been put out there, that's not even a drop in the bucket. So, you know, exactly unclear as to whether there'll be more money to support this kind of initiative, but we'll see where it goes. This is what the facility assessment, that's just a small part of what they added, but I just highlighted a few things. The medical director is supposed to be involved per the regulation now. That's something AMDA had advocated for, and hopefully you all agree with that. And you are supposed to get input from resident representatives and family members, which is very interesting. And it's asking for, as you'll see highlighted, sufficient number of staff for what your facility is. So the facility assessment becomes a key piece to this. And as I said, that's happening right now. Where we are, we've had a response to the proposed rule. I think we're somewhere in the middle of all of this, basically saying that it should be based on acuity. You know, you really need to be looking at what your facility needs are. Medical directors need to be a part of the facility assessment, as just mentioned. And, you know, it shouldn't be a fixed ceiling. So essentially, will those facilities that are staffed above the current minimum now say, well, you know, the minimum is 3.48, so that's all I need to do. So can that have a negative impact that way? Because if you're focused on a specific number, that becomes where things are instead of what the actual needs are. And that's something, I don't know if Leslie, you want to weigh in, but that's something the board discussed. They have a letter to CMS, which in my read didn't quite change anything from this position, although I think there was some discussion about being stronger in terms of the staffing mandate. And so that's kind of where we are with that. I don't know if there's any questions or not. I can't see the chat, but maybe we'll hold them till the end. So let's talk about, you already talked about the Part A payment. Let's talk about Part B payment. That's how they pay you all. What we covered in the SNF rule was how they pay the facilities. This is how you pay. That's again also my daughter who plays chess. For those who don't know, I'm a longtime competitive chess player, so that's what she was doing. So the fee schedule, the proposed fee schedule on the Part B side just came out in July. There's a proposed cut of 2.8% to all Medicare Part B services, so all of you would be cut 2.8%. This is not a CMS thing. I'll talk about it. It's really a congressional issue. There's also some things on alternative payment models, such as accountable care organizations, some decent changes. Two big changes on the primary care side. They are underwhelmed, CMS that is, on the coding of chronic care management and transitional care management. Those were the two codes that were put in to boost primary care. They are not serving their purpose. And so they are proposing to completely rework that and create tiers of codes in advanced, what they're calling advanced primary care. That's something to take a look at to see where it can be billed, how it can be billed, et cetera. Some of the requirements to build those codes are not changing that much. So, you know, we'll see what happens. And then on the telehealth side, I'll talk about it, but there's a positive proposal there to, even if Congress does nothing to extend the current expiration of telehealth, there will be no limitation on anything related to nursing home subsequent care codes. So there would have been had CMS not acted on this. And so that's a victory for AMDA. That might be confusing to folks that are not billing telehealth or don't know the particulars. But we can cover that. So this is where you are. Why do you see there's two conversion factors for this year, if you weren't aware? You were facing a cut last year. And so Congress didn't fix this until March. And so you got two different payment rates. So from January 1 to March 8th, you had a payment rate that was cut by 3.37%. And through March, through the rest of the year, it's only cut by 1.66%. So, and that is because Congress passed legislation to avert the entirety of the cut. They usually do that before the end of the year. That did not happen. They went all the way till March. CMS couldn't hold claims that long, and that's why that happened. So this is a problem. You have a cut last year, you have a cut this year. So what's going on? So there's long-term solutions being proposed so that we don't do this on an annual basis. And the basis for the solution is to tie Medicare physician payment, or physician fee schedule payment, I should say, because remember, under physician fee schedule, there are a lot of billing that goes under that fee schedule. Nurse practitioners bill under that fee schedule, physician associates bill under that schedule, labs, OT, PT. There's a lot that's billed under the physician fee schedule. It's just that's what its name is. And so that's the only structure that's not tied to the Medicare Economic Index. There's no inflationary update year to year. The SNF, skilled nursing facility, the hospital, every other payment is tied to that inflationary rate. The only one not, the physician payment rate. And so that gives you already you're starting behind the 8 ball because you're starting below everybody else. And then if you're cut, it's exponential. So even if you get a 0% update, you're still getting cut because you're not keeping up with inflation. That's kind of what that means. That's what this graph essentially shows. So there's legislative proposals. At the beginning, I mentioned these big pieces of legislation at the end of the year. So what's going to happen is we are hoping that one of these either makes it in or this becomes the starting point for next year, which is more likely, that we finally solve two things. One is to tie physician payment to the Medicare Economic Index, and the other thing is to get rid of budget neutrality. That's the other problem within the physician fee schedule. I mentioned things like the transitional care management and chronic care management codes not being billed as much as CMS thought they were. So that means there's money that's being left over that CMS thought that they were going to have to pay out that they didn't. The problem is, do you think that money goes back into the fee schedule? It does not. It goes away. So it goes away from that pie. So what you want to do is if you get rid of budget neutrality, you can actually grow the pie of physician payment that's available so that the surgeons in primary care, et cetera, are not fighting over, as they call it, scraps and fighting with each other. They can kind of let the tent grow and support additional services that can be reimbursed rather than trying to divide that pie into smaller and smaller pieces, which is what happens now. On telehealth, this is where we are right now. You can do all visits, subsequent care, medically necessary visits via telehealth without restriction. You have to do initial visit in person. There is no telehealth option. All home care visits can be done via telehealth. So a lot of exemptions dealing with rural exemptions and others are expiring at the end of December 31st. And so some may say, well, telehealth is ending. That's what they'll say in December. It is not ending. It's simply the provisions, the exemptions that were given to you during COVID are expiring in December 31st, 2024. And we go back to kind of pre-COVID era rules. It's not like you can't do telehealth. There are just parameters around it. No one really wants to go back to that kind of scenario and limit telehealth because they've seen a lot of benefits, including members of Congress themselves. During every hearing on this issue, members of Congress have told personal stories of how they have used telehealth and how they've liked telehealth. And so we know that if it benefits members of Congress, then it will get done. So that's kind of where we are. And so this is one of those, there's two proposals. One is to extend by 2 years, and the other is to extend it permanently. There's probably only enough money, if you will, to extend it by 2 years because, again, budget neutrality. If there's a cost to the bill, you have to find offsets. And if it's a permanent extension, it's a high cost item, not likely to go through. 2-year extension, kick the can down the road, much more likely. So this probably has the most support to make it into one of these end of the year packages because of expiration on December 31st of a lot of these provisions. And so Congress deals with deadlines in that way. Go ahead.
Oh, thanks, Alex. There's a question from Singh.
Yeah, I see that. Go ahead.
Sorry.
No, I think just wanted to clarify. I think you had in one slide that the telehealth doesn't expire till CY 2023. And this one says no restrictions until end of 2020, or no, the other one said 2025.
Oh, sorry, that's a typo. Yeah, that's a typo. Sorry. I haven't caught that in like, you're the first person to catch that in like 3 presentations. Congratulations.
Well, Greg had that in the chat box as well.
Oh, thank you. Yeah, you all are paying attention more than others. I'm very excited about that. So yeah, no, that's a typo. So again, yeah, everything expires this year to 2024. And the only thing that does not is that restriction on telehealth visits on subsequent care codes. CMS is proposing to extend that through 2025. All right, so let's talk about favorite topic, MIPS and MACRA and where all of that is. I don't know how many of you are paying attention to MIPS. It seems like everywhere I've gone, there's just people just don't seem to care as much as when I presented this prior to COVID or and whatnot. But MIPS penalties are real. And if you're not doing anything, you can get penalized as much as 9% of your Medicare dollars. So that's huge. And so it's important to get back to it. There are changes that they're proposing in MIPS. It would take forever to get through. It's pretty in the weeds. But you need to be, if you are not in an alternative payment model, such as an ACO or something else that counts, you do need to be doing MIPS. If you're in a multi-specialty group, maybe somebody's reporting for you or whatever, just fair warning, ask about this. What are we doing about this? Am I exposed? What's my situation here? Do I need to be reporting, etc.? We could obviously help with that. There's websites and whatnot. There are EHRs out there that'll help with reporting. But that's kind of where it is. There are, as I said, also changes on the MACRA side, on the alternative payment model side. There are changes to the Medicare Shared Savings Program. They are trying to, if you've shown a history of savings, they will essentially pay you upfront rather than waiting until the end of the program, because a lot of people are complaining that they can't make investments in the program if they have to wait until the end of the year to realize savings and then wait even longer for CMS to send you a check. So if they want to enhance their program and enhance their services, and CMS knows that you've shown a history of savings, they will actually give you money up front. So that's kind of an interesting wrinkle in some of this. And we'll see. That's all kind of a proposed rule. There are also additional models that are out there that are being proposed. One is called Making Care Primary. The other is called an ACO Flex model. Again, they're trying to boost primary care, and they view that these kind of models are the way to do that. These are all experiments. The Medicare Shared Savings Program, and now is more in the regulatory. It comes out from CMS. It's in the regulatory sphere. These other ones like ACO Flex and ACO Reach and Making Care Primary, they're all out of CMMI. They're more still kind of an experimental basis. There are demonstration projects, so a little bit different. You have to actively fill out an application, et cetera, et cetera. So that's kind of where we are. Importantly, though, a version of any of these models is going to win the day by 2030. They want, they being CMS and then the goal of the administration, and that's not a partisan issue. Under Trump administration was the same thing. They want everybody under these kinds of arrangements by 2030. My calendar says we're in the middle of 2024. If you're talking about developing models, that's not a long time. So I would suggest that if you have not heard about this, if this all sounds like a foreign language, then you need to seriously think about what your strategy will be moving forward. So looking ahead, where are we going to be? There are changes in the market. We heard in particular in Colorado, the role of venture capitalism, the role of private equity, the role of value-based medicine, the role of consolidation. Our physician practices becoming more employed practices, less independence, et cetera. Having to invest in additional infrastructure, whether that be electronic health records, interoperability, all those kinds of issues. The picture there is very recently we were at the White House for an immunization summit. You just had a presentation about this. So clearly there's a lot of focus from the administration to improve vaccination rates in facilities of RSV vaccine, RSV, COVID, and pneumococcal vaccines. So not much to say there other than we are working to ensure that reimbursement structure is there, because it's a great goal to have everybody vaccinated, but if we don't have the infrastructure and the reimbursement to do so, it's a goal without a plan, which I think they call those dreams. So we don't want that to be a dream. Interoperability, big issue. We are not where we need to be, although I will tell you, having participated in a lot of meetings, we are much, much further than we used to be. And I think we're much closer to getting some true interoperability than before. It's just, should have been a lot further along. If the ACO and whatever topic sounded like complete gibberish and foreign language, I strongly suggest that you view the recording from this webinar that we held on November 17th. It's not a webinar, it was like an all-day thing. And it goes from value-based 101 all the way through how do you do these contracts, etc. So highly recommend. We have a new coding guide, a lot of changes. So you should know about that. Moving Needles is our project. Leslie knows all about that, and others on improving immunizations. We will have continued kind of success around that. CDC mentioned it by name during our meeting at the White House, so it's getting a lot of attention. If you haven't seen our new website, please go and check it out. Our member forum, lots of postings there. Ask questions. Not surprisingly, Christian Bergman there, pictured, has already posted a few things. Others have as well. And then you can listen to our podcast. The name will be changing, as you know, but I host one with AMDA on the Hill. I'm probably going to record one with our chair of policy, Tim Holohan, shortly. And then I think Dr. Bergman will be doing some about state activities. That's me running in a marathon. If you want to contribute to my success there through the Leukemia Lymphoma Society, feel free. And if you have any questions, there you go. Somehow I did that in Georgia. It took me an hour. Here it took me like 20 minutes. So there you go. I talk even faster.
Thank you very much. That was very helpful. Does anyone have any questions for any of the speakers? We do have a few announcements, but everyone's been very patient with their questions. So I want to open it up and see if anyone has any questions. You can unmute yourself. You can put comments in the text. There was some back and forth whether or not RSV or if being in a nursing home makes you at high risk for RSV. And it looks like, I'll let Dr. Gahm answer that real quick.
Yeah, the answer is yes, you're at high risk. But if you look at the product inserts, you're not identified as one of the groups that should get RSV.
Okay, great. Jenny has posted a link to a sample facility assessment on her blog. And so that is in the comment section. And then I think Leslie Singh, we have a few announcements in the few minutes left.
Sure. Yeah. Alex mentioned what I was going to mention. So as you all know, our organization, either AMDA or CMDA, started many years ago, initially with medical directors who wanted to improve their knowledge and create a community. And that's where the AMDA title came from. In just 1 week, the name of the national organization is changing, and it will no longer be called AMDA. We're going to be called a name that more represents the larger scope that we have, that it's not just medical directors in our space who need to know the medicine that takes place in post-acute and long-term care medicine. It's not just physicians. It is the whole interdisciplinary team, and we have a much broader scope than we previously did. So in a week from now, instead of being called AMDA, we're going to be known as the Post-Acute Long-Term Care Medicine Association, or PALT Med, P-A-L-T Med. And you'll start seeing that on Alex's slides and on the website and all the material. Currently, because we have a lot of different priorities, we're going to keep the Colorado state chapter name. So you won't have to change the way you're talking about our local organization, not just yet, but we're not making any changes at the moment, but wanted to make sure you all knew what was coming.
Great, thank you. I know I just have a couple. Did you have some, Dr. Ebert, Leslie? Did you have any announcements?
No, I was just
Okay.
going to be available for anybody who has questions about the new name. We're really excited. It really states who we are much more clearly, and it's much more inclusive. So just available for questions.
So I know it's very, very early, but we want you all to save the date for Friday, April 25th, 2025 for our next annual meeting. And in saying that, if you guys, because we want to represent the community, if you have any suggestions, please, I know you fill out those long surveys right immediately after the conference, but if you have if things have come up since then, we're beginning the planning stages. So if you have topics that you'd like addressed, please let us know. We're also very excited to announce an in-person meeting. We're going to do that at least a couple times a year. So that will be October. So our meeting in October, we will attempt to do both. We will offer in person, and then we will attempt to offer a virtual option at the state health department, and we will send out an announcement, the exact room. In light of that, one of our goals is to reach people in rural areas. So we're looking at options for offering some type of scholarship or some type of assistance to bring those people in if they want to come in. If you guys have any suggestions, if you are a rural member and you feel like it's a hardship or that's something you'd like to participate in, please email us, Singh, myself, Dr. Eber, and we will work on making that happen. Wow, 1 minute over. Thanks for everyone's patience. Appreciate your attendance. There's a lot of great information today. Thank you.
Thanks, Chris.